Good afternoon, Chairman, Co-Chairman, and our audience. My name is Chanapai Yingnoirat, Fellow from Basem Bangkok Hospital. Today, I'm honored to present the topic Knot versus knotless anchor for Bankart repair, evaluating efficacy and outcomes. I would like to thank to my advisor for their supporting. The Bankart lesion was first described by Dr. Arthur Bankart in 1938 as an anteroinferior labral injury causing anterior shoulder instability. And if the Bankart lesion occurs with a bone fragment and associated glenoid defect, we can call the bony Bankart lesion. MRI is an excellent diagnostic tool for detecting this lesion, and the arthroscopic technique, instrumentation, and implant material play a significant role for the treatment. Arthroscopic Bankart repair using suture anchors is the standard and most commonly performed procedure for anterior shoulder instability. It can restore the anatomy, achieve favorable outcomes, and minimal invasive procedure. And indications for surgery include more than one dislocation or subluxation with Bankart lesion, recurrent dislocation with failed conservative treatment, the patient who are high risk at least, or who fail cross reduction. There are two types of suture anchors using for arthroscopic Bankart repair. The first one is the knot tying suture anchors, and the second one is the knotless suture anchors. However, the choice between knot tying suture anchors versus knotless suture anchor remains debated. For the knot tying suture anchors, I will show you in this video about the technique. After identifying the Bankart lesion, use the Bankart knife for labral mobilization. Then perform the bone bed preparation before suture anchor placement. The first suture anchor was placed at inferior glenoid level and used the lasso suture for passing device. And apply the knot tying suture technique and cut the suture respectively. For the second, third, or fourth suture anchors were placed from inferior to superior glenoid level, respectively, and check the stability after finishing repair. The pros of knot tying suture anchors are traditional technique, reliability fixation, and cost-saving procedure. But the cons include the outcomes of the repair depends on the quality of the knot. It can damage the articular surface of the humeral head, and the recurrence dislocation will form 4-19% in some literatures. So in 2001, Dr. Tall introduced the first generation of the knotless suture anchors for treatment of the labral injury and can resolve the problem with knot tying suture anchor. There are many types of knotless suture anchors. In the past, metallic knotless suture anchor was used. This is a rigid fixation, but there were some complications, such as articular cartilage damage, implant migration, loosening, and it's difficult to revision surgery. So it developed into bio-knotless suture anchor. This is a biodegradable type, and the peak knotless suture anchor. This is the permanent type. And there is some studies comparing these two suture anchors and found that no statistically significant difference in terms of complication or functional outcomes. And this is the new generation of the knotless suture anchor, the soft or suture knotless anchors. It can preserve the bone stock, decrease risk for glenoid damage, improve post-operative imaging, and it can facilitate easier revision surgery if necessary. For the knotless suture anchors, I will show you this video about the technique. After identifying Bankart lesion, place the knotless suture anchors at inferior glenoid. Retrieve the repair suture from anterosuperior portal and use the suture lasso for passing device. And retrieve the repair suture back to the anteroinferior portal. Place the repair suture to the loop end of the shuttering suture and pull the free end of the shuttering suture to create the self-locking mechanism. Then apply tensioning and cut the suture. And use the same manner from inferior to superior glenoid level, respectively. And by applying the tension, use the grasper to hold capsular labral tissue for securing the fixation. The advantage of knotless suture anchors are technically simplicity, low profile repair, and it can reduce the operative time. And there are many studies about knotless suture anchors for Bankart repair, and they report that the knotless arthroscopic Bankart repair significantly improve the functional outcomes such as ACS score, SNE quick dash, and SF12 score. However, the recurrent dislocation were about 10 to 20% in some papers. And the knotless suture anchors can cause some problems as shown in this video. The first knotless suture anchor was fine, but the second one has some problem, as you can see. Don't blink. While pulling the shuttering suture, it broke, leaving only repair suture. So we used the free suture and tied together with the remaining repair suture to resolve the problem. However, this is the old generation of the knotless suture anchor, so it might not be as strong as the new generation. So which one is the better between knot tying suture anchor or knotless suture anchors? Today, I'm going to talk about the biomechanical aspect, clinical and functional outcomes, radiologic outcomes, complication, and cost effectiveness. The biomedical outcomes. The study by Dr. Ben includes 15 fresh frozen cadaveric glenoid reports that the knotless suture anchors provide higher average load to failure, around 200 newtons. The study by Dr. Renobat published in the American Journal of Orthopedics in 2011 found that no significant biomechanical difference in the ultimate load to failure or the stiffness. And the biomechanical study from Dr. Ruka comparing knotless and knot or suture anchors with simple and horizontal mattress configuration reports that no statistically significant in the first failure load, ultimate load, or the stiffness. However, the knotless suture anchors show fewer suture slippage. And if applying with horizontal mattress configuration, it can reduce the capsular strain significantly. And the biomedical analysis published in the American Journal of Sports Medicine in 2023, they found that no significant difference in elongation during cyclic loading, stiffness, and ultimate load to failure among soft body knotless, soft body knot, and hard body knotless anchors. So for biomedical study, we can conclude that the knotless suture anchors show comparable or superior outcome compared to knot tying suture anchor, because in some literature, they show that the higher load to failure and reduced suture slippage with knotless suture anchor. For clinical and functional outcomes. The retrospective study by Dr. Cho from 2001 to 2002 reports that the functional score significantly improved in both groups, but the knot tying group show better results of post-operative pain, patient satisfactory score, and recurrent dislocation. The prospective comparative study of Dr. Dennis from 2007 to 2011, they found that both knot and knotless suture anchors show significant improvement in visual analog scale and constant scores, but no statistically significant difference between two anchors. The study by Dr. Estan published in American Journal of Orthopedics in 2017, they found that no significant difference in patient-reported outcome measurements, but the knotless suture anchors had significantly shorter operative times, around 5 minutes per anchors. And the study by Dr. Andreas also found the same outcome as previously paper. They also found that the knotless suture anchors had shorter operative time, about 20 minutes per operation, but no statistically significance in the functional outcomes. And the systematic review published in the Journal of Arthroscopy last year, a total of 9 studies involving more than 700 patients, also found that both knot and knotless suture anchors show comparable in visual analog scale, roll scores, and range of motion in external rotation and forward friction. So for the clinical and functional outcomes, both knot and knotless suture anchors show significant post-operative clinical improvements with comparable patient-reported outcome measurements. However, the knotless suture anchors can reduce the operative time significantly. radiologic outcomes. A single-center prospective randomized control trial of Dr. Federico showed that the MRI showed no significant difference in variable healing or morphology at 24 months post-operatively, and no significant difference in the functional score as following. Complications. The retrospective of Dr. Jai from 2011 to 2017 found that the redislocation was similar between two suture anchors after a minimal 2 years follow-up. And a study by Dr. Federico, as I previously mentioned, also found that no statistically significant difference in complications, such as recurrent dislocation or subluxation. And the recent synthetic review includes 7 studies found no significant difference in the complication, such as recurrent dislocation, subluxation, or revision. But the study by Dr. Cho report the redislocation was higher in the knotless group significantly. So for the complications, we can conclude that both knot and knotless suture anchors show comparable in complication rate. However, some studies found more redislocation with knotless anchors. The cost-effectiveness. The knotless suture anchors may improve the cost-effectiveness because it can reduce the operative time. By the way, the knotless suture anchors is more expensive than the knot tying suture, about 5,000 baht. So it recommends that in high-volume centers, time savings may justify the cost, but the smallest hospital, the cost effectiveness is debatable. So how to choose between knot tying suture anchors or knotless suture anchors? From the evidence-based clinical guidance, I would suggest that if you want to faster surgery and easier technique, it's better to use the knotless suture anchors. If you want a cost-saving and widely used procedure, the knot tying suture anchor may be your answer. And if you're concerned about the revision surgery, it's better to use the knotless suture anchors, and the soft anchor is preferred. In conclusion, both knot tying suture anchors and knotless suture anchors are effective for arthroscopic Bankart repair with comparable biomechanical and functional outcomes. So the choice depends on the surgeon preference, patient-specific factors, and the hospital resource. Thank you for your attention.